Hello, we're back. Last lecture for the semester. Yay! I'm sure you're excited to be done. I know I am. I love the fall semester because it always ends on the holidays and you have a nice break before you start the next semester, get a little relaxation. So exciting. All right. Dermatology is a relatively quick lecture. So lesions. Lesions basically are skin that's different from the surrounding skin. It may be normal. It may be due to an injury or a pathologic change to the tissue. It may be caused by underlying disease. So all lesions should be assessed for size. So it should be measured, depth, odor, drainage, pain, color, contributing factors, and a history, of course. So flat lesions, we have a macule. This is a macule, totally flat, just a different color than the rest of the skin. Fissure, which is right here where you see some breaks in the top layer of tissue. You have erosion atrophy, so where the tissue has now become smaller. So you see down here on the left lower, this is probably like almost like a scar tissue here, which is, scar tissue is always smaller or not as elastic as regular skin tissue. And then ulcer right here, where it's actually gone through the top layers into bottom layers of tissue. Raised lesions, you have papules, you have patch plaque. This is plaque right here. You have a wheal, which is basically like here, like an allergy or hives. A nodule. Do I have a nodule here? I guess this would be like a nodule, a raised area, not as big as a wheal, a little bit smaller. Keloid, let me move me out of the way here. You don't need to see me. This is a keloid where it's actually the tissue is expanded and it gets very large. And lichenification, this would be lichenification here, where you actually have, if you know what a lichen is like a fungus that grows over trees. If you think of that, lichenification doesn't always mean that it is a fungus though, but it's just kind of it's raised, but not super raised, and it just kind of spreads out. A scale and a scar. So these would be papules down here. This is just kind of your scaly skin here, and a scar, which is a keloid, and keloid's also a scar, but it's just a raised, really raised, almost like double the tissue that would normally be there. Fluid-filled lesions, vesicles, these are vesicles here. Vesicles have serous fluid in them. That's looks like a nasty one, and maybe like a burn or something to here, maybe, I don't know, or like I always get this for poison ivy. This is what always my poison ivy turns into, these vesicles. Ebola is like a bigger vesicle. It's probably like that. Pustula here. A cyst is under the skin right here. So these are probably the vesicles, and this would be bulla here. So vesicles tiny, bulla bigger. And they're full, vesicles and bulla have serous fluid, and pustules obviously have pus. So skin healing, first of all, you have an injury to the skin, so now it needs to heal. So you have bleeding to that tissue, so that leads to clotting factors into the site, along with platelet aggregation to stop bleeding. Then you have the arrival of your inflammatory response, right? We've talked about this all semester. Inflammatory cells, such as neutrophils, are going to come in. They release cytokines and other mediators, and then the fibroblasts make a scaffolding for the skin to regenerate on. And then you have angiogenesis, and this is new vascularization. That's what that word means. And re-epithelialization, where the skin is starting to come back. It is not exactly the same as the skin that was there. It's a little bit different. It depends on how deep the injury was as to what kind of tissue will come back. If there's a tissue loss, then that's a problem that it may fill in very weak, kind of more of a scar tissue, deep scar tissue. Granular tissue formation, that's that red tissue, when it's maturing and remodeling. So you have a lot of vasculature there. So it's very beefy red. And that's granulated tissue. And then the scar tissue comes back. Scar tissue does not have hair follicles and it does not have sweat glands. So here we kind of see the different stages of wound healing. We have the injury right here. So you have an injury, so a clot comes into here. A clot then basically causes that sealing of the injury. And that is caused by coag factors and complement factors, which we've talked about before. We have our inflammatory process. So you have your DAMs, your PAMs, and your cytokines coming in, and that causes this release of macrophages, neutrophils to the wound, leaks from the vessels. Remember, cytokines does that. And then you have angiogenesis, where you have more vasculature kind of growing in there so that the growth factors and other tissue mediators get there quickly. Then you have cell migration and proliferation, so the new cells are starting to grow. You have growth factor, cytoskeletal regulators, and cell adhesion proteins. And then you have resolution factors where you have the sealed epidermis, new tissue there. Again, it can, most of the time tissue is smaller, but if you have keloids, it's way more. You see here kind of this process. You develop this eschar right here or a scab. Eschar is a scab, and that is blocking anything from getting into this process of healing. And then once that healing process is done, this scab will kind of dry up and just fall off. So we don't like to pick at scabs. The thing with scabs though is it will kind of tighten the skin around it. So sometimes for a more appealing scar, they might, like a plastic surgeon or someone might remove the scabs so that air can get to it and that you don't have quite as much scar tissue forming there. It just kind of depends on the damage that was done. Inflammatory disorders, we have eczema, which itches, it's pyretic, lesions with distinct borders, epidermal changes. You have, it looks just like this. It's edema comes there, you have a serous discharge, crusting occurs, and that's what causes that itch. And then you have continued irritation from scratching, from the itching that causes scratching. And then it can scar over time if, you have too much scratching or disruption of the tissue. Allergic dermatitis, this is a reaction to antigens, allergens. It becomes reddened, it becomes swollen. You have pyretic vessels and maybe wheals, and they can get bigger, smaller, they can change shapes on you. I remember this one kid, I'll never forget it. I can't remember what he was allergic to. It was some antibiotic, I think. And I was working at the health department at the time in this clinic, low income clinic, and they brought this kid in and he had all these hives on him and you could just see him changing shape in front of you. And I'm like, oh, never seen that before, but they were just getting bigger and then smaller, bigger. It was just uh, wild. So he went to the emergency department because obviously it was a little more than just your typical um, hives. Atopic dermatitis, this is sort of like an allergy response. You have scaly patches. It is an inflammatory process. Things will trigger it, but it's not a true allergy. So usually atopic dermatitis, allergies, and asthma kind of go together. So kids that have one of those is at high risk for one or the other or all three, which is not unusual. My husband has asthma, but he also has atopic derm, which atopic derm is kind of, lot of research and things go into atopic derm. There are some medications out there to help it, some biologics to kind of decrease the immune response because some people get it really, really bad. With seborrheic dermatitis, this is an inflammation of the skin. It can involve any body part, and it's an alteration in the stratum of the skin that allows water to more readily leave the skin. So it's like a scaly, patchy kind of tissue there. Not typically itchy, but maybe if it's getting really dry or something like that, but not typically, but it will flake off. So you have these flakes, and it's almost like a plaque kind of thing going around there. And the most common place that you'll see this is on the scalp, with like dandruff. That's a seborrheic dermatitis. And so that tissue is flaking off. And so, yeah, it's more of a cosmetic thing. It doesn't really cause scarring or anything like that. Um, it tends to be where the stratum of the skin is not sloughing the way it should, and it builds up, builds up, builds up, builds up until then it starts to flake and it's big flakes coming off. Psoriasis, the dermis and the epidermis are thickened and that cause a keratin site uh, hyperproliferation and expanded vasculature. So another plaque-like thing going on. Psoriasis is treated with other kind of medications different from the seborrheic dermatitis. And psoriasis, again, can be you can have like painful psoriasis and even joint issues with the psoriasis that might go along with it. So quite distressing for people. Piteous rosea, it's in children and young adults. It's like a herpes-like virus, and you usually see this herald patch. So this is the herald patch right here that goes along with that. Um, Another inflammatory is acne vulgaris or zits, if you want to call it that, acne. And this is inflammation of the sebaceous gland, and it's contiguous with the hair follicle. So it's in the sebaceous gland, and it gets like full of pus, basically, and it can get quite big and it can get quite painful. Some people with it will actually have like really deep cyst-like acne that is quite painful, and it will get large, and then they have it so much that it starts to scar their face. So there are medications as well for acne. Sometimes we use some antibiotics to help with that. Some people tend to get more than others. My son's had it terrible, when he was doing growth spurts, and that's kind of a flux. You tend to see it more with like puberty, and then they kind of outgrow it, but some people don't really outgrow it. They have it all the time. Here I am, an old woman. Every once in a while, I get a pimple, and I'm like, are you kidding me? I had enough of this in high school. I don't need it now. Anyways, and my daughter, I think I've seen one pimple on her whole life. So some people are fortunate they never get it, and some people get really, really, really bad. So it's kind of it's almost, I don't know if it's a genetic thing. I mean, but there probably is some genetic relationship to that. Oh, that's our last slide. See, quite kind of quick. So we have a review session on Tuesday, but if you have specific questions you want me to go over material, or if you want to see their old quizzes, please schedule a time with me so that, we can have some one-on-one time. Pretty open this week and the following week, so we can get you taken care of before you take your exam. The exam is 75 questions. If the questions are similar, it is over the entire semester material, and pretty much topics that we've covered on previous exams, but there might be other material that will be on there as well. So remember, 75 questions. There will be 20 questions on reproductive and derm, and then the rest, the 55 questions on everything else. So 20 questions on derm and reproductive, not 20 questions each, but 20 questions total on those two lectures, and then 55 from previous material. All right, let me know if you have any questions, you want to see quizzes. I'm happy to meet with you.